Hello, it's Dr. Shelley again with Shelley's Nursing Review, and as promised in the last video, this is going to be part 2. Now remember, at the end I'm going to show you how to go about getting your freebies from my wonderful YouTube channel. So don't worry, I got your back. I mean, for real, I have an oh my god packet that you don't get charged for. You just have to reach out to me. I'll show you how. That has everything you ever needed to prepare for your NCLEX exam. And yes, it has the tips for how to pass the NGN NCLEX exam, because it's really different. So of course I go into great detail about clinical judgment and the case study stuff. That don't be afraid of those. I hear they're not that bad. We've had our first student take her NGN NCLEX exam a couple weeks ago, and she thought it was a breeze, 85 and out. So look for that video as well. It's in the inspiring testimonies. There's a ton of videos about nurses that are really excited because they passed their tests and now they're practicing. And so again, pay attention to the playlist. It has everything you ever needed. It's organized by systems and disease processes. So today we're in this handout. So students, get your handouts out. And I want to show you that this particular handout, it has everything we're going to talk about in part 2 of peptic ulcer disease. Specifically, the page that we were doing in part 1 is the page that literally says peptic ulcer disease. But I love this packet that I made for you guys because it's not just the peptic ulcer disease. It has the medications that we're going to be talking about today, like metronidazole. It has the category of meds that we use to treat peptic ulcer disease, like some of these antacids, which is down here. It has another antacid that sometimes we use. It has a category of medication called proton pump inhibitors. You can see here, I spent a little bit of time on proton pump inhibitors. And it even gives you an example of a proton pump inhibitor. And if you turn the page, and this is all in one packet, you'll see the H2 blockers. Here we say the histamine receptor blockers. So you got this. And then of course sucralfate, which is a coater for the stomach. So you see this down here. So if you need one of these, remember, I got your back. You just have to reach out to me. And at the end of this video, I will be giving all my information for you to be able to do that. So again, remember, we're in this packet. And by the way, nurses, this is your chronic GI, not acute. Okay, so let's get started. As promised, I told you in part 1, and of course, if you're here and you haven't seen part 1 of peptic ulcer disease, or even my gastritis video, then you're going a little out of order. You'll want to go over to the playlist and look under GI, and then you'll see all my videos are literally in order of how you should be watching them to prepare for your NCLEX exam or your nursing school unit test, okay? So let's hit it. We said in part 1 that we were going to compare and contrast the differences between gastric versus duodenal ulcers, because let's just say a little birdie told me that you might want to know that, especially when it comes to select DAWs and case studies, okay? So here we go. The patient with the gastric ulcer, remember what I've been saying since 2 videos ago, is that if I say gastro, I'm talking about the stomach. So this ulcer is in the stomach. This ulcer, duodenal, is in the small intestine, the first part of the small intestine. So if you remember your anatomy, you have a duodenum, a jejunum, and an ileum as your small intestine, like 300 feet, right? Okay, so now if we go over here, this gastric ulcer patient really has to eat to feel, I should say either, scratch that. This patient with the gastric ulcer is either going to be malnourished and losing weight because every time they eat, they hurt. So literally every time they eat, they have the classic hallmark peptic ulcer symptom of terrible pain, and it happens 30 to 60 minutes after meals. It's usually in the epigastric area, a little bit over to the left upper quadrant, and it's awful. So eating does not bring them pleasure. So look for that as a difference, because here with the duodenal ulcer, this is very different. For this patient, they're well nourished or maybe even obese, and for them, they literally find that eating works for them, you know? So it's relieved with eating, and their problem times are when their stomach is empty. So they have a tendency to want to put something in their mouth all the time. Literally about 3 hours or so after meals, they are feeling their pain, and even at night, because we're not bending our elbows, shoving food in our mouth at night, this patient wakes up in the middle of the night with serious pain. So that's a big, huge, you might want to know, difference between gastric and duodenal ulcers. Let's take some more looks, shall we? The patient with the gastric ulcer has a hyposecretion of hydrochloric acid, or maybe just a normal secretion. And that's important because that low secretion, or slightly normal, slightly low, will produce a delayed gastric emptying. What do I mean? I mean to tell you that the food stays in the stomach longer, and so it's sitting there and sitting there, taking its time getting out, and that the hyposecretion or decreased HCl is directly impacting how fast your food can be digested. So you slowed digestion when you don't have enough of this acid. And it could be just that the irritating substances that cause this condition, like the H. pylori or the NSAIDs, have destroyed the gastric mucosa to such an extent that even the parietal cells don't produce as much hydrochloric acid as they used to. And so you have that delayed gastric emptying, and so that's a big deal. Now, on the other hand, the duodenal ulcer patient, they have just the opposite. They definitely have a hypersecretion of hydrochloric acid, and that extra secretion of hydrochloric acid is causing rapid gastric emptying because you've kind of eroded the pyloric sphincter with all of this hyper production of acid right at the top of the duodenum, the beginning of the duodenum, and at the end of the stomach. So if you picture the stomach here emptying into the duodenum, right between the stomach and the duodenum is a sphincter, a pyloric sphincter that delivers food slowly, methodically, and gently. Well, this hypersecretion of acid is causing an erosion and an irritation of the pyloric sphincter, leading to rapid gastric emptying. Okay, so, you know, this is very serious stuff. Now, there's good news and bad news on both sides, right? Let's deal with the good news, shall we? The good news with gastric ulcers as part of this patient's peptic ulcer disease. The good news is this patient usually heals with treatment. As long as they stick with their treatment, they're not going to have drama in the club. The bad news. The bad news is that the gastric ulcer patient has a higher risk of cancer of the stomach. Like, ew, that's ugly. So that brings me to the good and the bad news over here. The good news, there is no higher risk of cancer with the duodenal ulcer. However, this patient has remissions and exacerbations. And you know that exacerbations are another word for flare-ups, whereas remissions is when it's not bothering you and it's calm and quiet and sleeping in the body. Okay, so that is our issue there. Now, as we go a little bit further, this will be a very big, huge, you got to write it down, make sure you know it kind of thing. The patient with the gastric ulcer will have hematemesis, blood in their emesis or when they throw up. It could be coffee ground or bright red. The bottom line is they will throw up blood. Now, coffee ground is still blood, but they'll just throw up blood. And that's because the gastric, if you'll remember me telling you that gastric is always going to mean stomach, and the stomach is closer to the mouth by way of esophagus, right? Now, this patient, the duodenum is a little further down in the digestive system. So whatever bleeding that was occurring in the digestive system has moved down and began to be digested. Remember, blood is a protein. And so this patient with the duodenal ulcer will have melena, which, as you recall, means dark, tarry stools. Very big, hairy deal, okay? Like, seriously. Now, one more thing, the last thing, I guess, the last couple things anyway, is that the patient with the gastric ulcer has usually a history of gastritis. And so there has been an ongoing historical chronic irritation and eroding of the gastric mucosa over time. And we see this quite a bit in these patients. And so if that's what's going on with this patient, it's no doubt that over time, if they haven't been treated, they're going to end up with this gastric ulcer. And it's not very genetic or familial, right? You got to know those terms, genetic or familial. On the other hand, there is absolutely no history of gastritis with this patient. This patient's issue very often runs in the family and is seen as genetic. Now, so you got a good understanding of the comparison and contrasting of these two peptic ulcer diseases. Now we need to move on and try to treat this patient. The good news, the treatment is the same for both. So we used to call it back in my day, they need triple therapy. Well, what the hell is triple therapy? Well, it's a proton pump inhibitor, or PPI, with 2 antibiotics. And which antibiotics we use is basically up to the preference of the physician or nurse practitioner and the patient's preferences or allergies even. So it just doesn't matter really. But the one I see a lot, like a lot, I see metronidazole, which, as you know, is Flagyl, and a tetracycline combination. And I want to say something about that metronidazole. You got to remember that metronidazole is a medication that you absolutely, positively cannot drink with. If you do, you will be violently ill. So you have to remember no alcohol with metronidazole, and then combined with the tetracycline, which is, you know, another antibiotic. Now, sometimes I'll see a different regimen, and I'll see the patient on clarithromycin, and I think the brand name is Biaxin, with amoxicillin. The problem with that, as you know, is that people can have a penicillin allergy. And as you also know, that penicillin allergies, if a patient has a penicillin allergy, sometimes it crosses over into a cephalosporin allergy. And so if that's the case, if the patient has a penicillin allergy, or if the doctor or nurse practitioner just thinks they need it, we will add or substitute bismuth subsalicylate. Yeah, what the hell is that? Well, it's the good old-fashioned over-the-counter Pepto-Bismol. What does Pepto-Bismol have in it? What is this fancy $4 word? Salicylate. It's aspirin. So this patient would not be taking aspirin with this treatment. They just need the aspirin in the Pepto-Bismol. And you know, I gotta tell you, Pepto-Bismol, if you put the patient on the Pepto-Bismol, it literally will help kill the H. pylori as well. It will inhibit the H. pylori as well. So it's a double whammy. It's like, woo, knock them out. Okay, now, so let's look at our PPI option for this patient if we're using the triple therapy. Again, a PPI with 2 antibiotics. If we're using a PPI in our triple therapy, you just got to remember it's a proton pump inhibitor, and PPIs, and in the last ending of the word is prazols. Omeprazole, esomeprazole, or whatever, right? So omeprazole or esomeprazole, those medications are examples of basically Prilosec and Nexium. Those medications work really well. They decrease the hydrochloric acid to begin with, and they're very, very, very effective. And let me just say, for the record, no matter what happens all through here, a patient with an ulcer, a peptic ulcer, will be put on a PPI till the day they die. They will take this typically for an entire lifetime of the medication, okay? Now, another alternative, if H. pylori was not even involved in any of this, which is rare because H. pylori is 90% part of the problem with both of these diseases, more so with duodenal ulcers, a little tiny bit less with gastric, but the bottom line is H. pylori is the cause, okay? But, you know, in a rare instance where the patient doesn't have any of that and they just have maybe some other things going on like overuse of NSAIDs or something crazy like alcohol, then a histamine receptor blocker, which is called an H2 inhibitor, is also an option. This is going to stop the histamine, which makes you produce hydrochloric acid and sets up an inflammatory process. So the H2 will work as well. Now you've got to remember a couple things. PPI, H2s, whichever one is chosen, they must be taken on an empty stomach, never with food. Now, I want to say, if you go down to the pink part of my board, some other less common options, but reasonable, depending on how severe the situation is. Patients can have antacids. This you would take after meals. It's not as common with the peptic ulcer patient as it is, with the duodenal ulcer patient, as it might be with the gastric ulcer patient. Also sucralfate, which is a stomach coating medication. Obviously, it needs to be on an empty stomach. And this is very important because for so many patients with a gastric ulcer, their pre-existing condition was gastritis, and sucralfate is the number 2 treatment for gastritis, right? It coats the stomach nicely to protect that lining of the stomach from erosion. Now, let's talk about some maybe lifestyle and diet stuff. I gotta get you to remember what I said in the part 1 video. Your diet does not cause peptic ulcer disease. Stress does not cause peptic ulcer disease. However, it's like salt and hypertension. Salt does not cause hypertension, it aggravates it. Well, stress aggravates peptic ulcer disease, and certain diets aggravate peptic ulcer disease, and certain medications aggravate peptic ulcer disease. So it's kind of like that. So let's look at how we can help our body heal and not make it worse, even though some of these things may not have caused the condition in the first place. You already know what I'm about to say. Never in your life ever, never, are you to take Advil, Aleve, ibuprofen, or Motrin. Your little ass better find some Tylenol and sit down somewhere. No more NSAIDs for you, boo. Typically, aspirin is in that category as well, because if you do have an ulcer, there is a very real risk that it could bleed, and aspirin will increase your bleeding risk. Steroids are another troublemaker. So unless there's some god-awful, crazy condition where steroids are necessary, and even then we'd probably look at an IV preparation, steroids can also really irritate the lining of the stomach and cause some problems as well. Now, they won't cause peptic ulcer disease, but they'll surely aggravate it, okay? Anticoagulants, for obvious reasons. Why would you take a patient with an ulcer knowing that they're at very high risk for bleeding ulcer and perforation and give them anticoagulants? You got to be careful. Caffeine can make this worse. It's not going to cause it, but it can make an ulcer worse. Okay, so we're not going to do caffeine. What kind of diet to help you heal until things get better? A bland diet, which to me means boring as hell. So what kind of boring as hell diet am I talking about? Well, bananas, rice, applesauce, toast, but you don't want to say brat diet on this test because brat diets have played out like bell bottoms and leg warmers. So you want to make sure when you talk about the diet, you mention the foods and not just say brat, although what I just gave you was a brat diet. Now, why can't the brat diet just be said and we get this over when we're playing games? Well, remember what I said, bananas, rice, applesauce, and toast. There's no protein in there, and that's crazy. So you need a protein in there. So, you know, we always say chicken fits in the bland department, baked chicken, broiled chicken, not Popeyes. No, I didn't say that. You said that. You have issues. I don't. And so, no, you want boiled or baked chicken, okay? Stop it. Now, bland diet. Avoid citrusy foods, acidic foods. Now, what do I mean about acidic foods? Is it foods with LSD? No, you retard. It's foods like tomatoey stuff, right? Bell peppery stuff, pepper stuff. Okay, just stop it. Fried foods can be irritating, and so you have got to learn how to leave your Popeyes at Popeyes, okay? Now, what else? Well, we said you don't want to do this. Stop your drinking. Leave the Hennessy at the club. Don't hide the Jack Daniels in your underwear drawer. You gotta stop. At some point, you gotta stop. Stop your smoking. And when it comes to stress, again, stress and diet do not cause peptic ulcer disease, which you gotta know that. But stress can aggravate the shit out of it. And you already know that because I talked about bubble guts in part 1. I talked about how when you took your first NCLEX and maybe failed it, you got bubble guts, and then you found me, and now I'm torturing you with homework assignments, and well, bubble guts continue. So, you know, stress, emotions, feelings can directly impact how you digest your food, okay? All right, now I hope this was helpful. So I have one more treat for you. I told you if you just stuck with me, hung in there a little longer, you would get the information to go ahead and get your freebie Oh My God packet. Oh, I'm sorry. What is the Oh My God packet? Okay, hold on, boo. You see this bad boy right here? This is your Oh My God packet. Well, what does it have in it? Well, it's got your tips for how to pass your NG and NCLEX. It's got how to use my YouTube my YouTube station to pass the NCLEX. It's got what scores do you need on your software to say you're ready for NCLEX. It's even got this wonderful little handy dandy NCLEX quickie, because we all like quickies. It's got prioritization, it's got delegation, it's got your labs that you care about, even though you don't have to know a lot of labs, you should know a lot of labs. It's got all of the immunosuppression, infectious disease, seizure precautions, any precaution you ever wanted, bleeding, neutropenic, whatever. It even has all your shocks. It's got some maternity and pediatric quickies. It's got all your diets in every position. It's got some Erickson stuff in there, and it's even got some ethical legal stuff to keep your little ass out of jail. Yeah. You might want it. It's free. I got pharmacology in here too. Like for real, like seriously. Reach out to me. I love you, boo. I'm one of the only bitches that gets shit off free. So look, watch this. Either you can text me at 216-410-0936. And I do know a lot of you listen to me in your car, so don't get in a car accident trying to text me. That's ignorant, foolish. Or you can reach out to me through email. If you reach out to me through the email, you just have to go to CHELLYS NCLEX PREP at that look ugly, don't it, y'all? I'm sorry, baby. At gmail.com. Now, of course, if you need the handouts that we use for the actual lectures, we have those too in a wonderful, very affordable self-study format, but that's not free, fool. So you're going to come up off your ducks for that. But otherwise, I gotcha. Deuces.